Good evening. How about that? Better? Okay, great. Hi. Thanks for coming out tonight. Really appreciate it. A special thanks to Dr. Padi and his whole staff from Young Scientist Roundtable. You young people have no idea how lucky you are to have a program like this, because parents, did we ever have anything like this growing up? No. And so, maybe we would have done something different with our lives if we had some exposure to something like this. So I really think this is a really valuable program, and I really want to thank everybody here tonight for coming out, especially the parents. Thank you for bringing your kids, and kids, thanks for bringing your parents, actually. It's better, right? A couple ground rules. I like questions. If you have a question, a lot of times you forget, go ahead and raise your hand. We've got plenty of time tonight to answer them. So if you think of something, go ahead and raise your hand and I'll call on you, okay? I'm going to go on a limb here and I'm going to ask, does anybody happen to have a laser pointer with them tonight? Come on, scientists. Oh, okay. We'll do the best we can. We'll do the best we can. All right. Yeah, exactly. So disclosures, I do consult for Arthrex, and I will be showing some slides of their products in my talk tonight. So what is an orthopedic surgeon? So, unbelievable. Big round of applause. I'm going to go buy one of those lottery tickets tonight, I think, too. All right. All right, so orthopedic, that is two compound words, Latin. What do you think ortho means? Any guesses? And what does pedic mean? Special type of doctor. If you put them together, it actually means kid. So it's like a bone doctor for kids. That's how we kind of started out. So but it's changed actually, right? We do something different now. So why do we get a bad time from all of our other medicine colleagues that work carpenters? Well, we use a lot of tools. So as you can see here, that's a drill, 18 volt. It's not a Makita, it's not a Bosch, but it's a good drill. We use a lot of those. There you can see a hammer, there's a screwdriver, and there's some reamers. So orthopedics is a very intensive specialty with a lot of tools. So if you like cars, you like carpentry, if you like to work with your hands, but you still like the intellectual challenge of medicine, this is a perfect marriage of those two things. But really, first of all, an orthopedic surgeon is a doctor, and this is a medical doctor. The letters behind my name, MD, me doctor, that is not like a PhD. It's a different kind of doctor. So we don't do a doctoral dissertation. We do research, but it's completely different. Now to go further, I'm also a surgeon. Now, unlike a lot of doctors who see patients and listen to your heart and lungs and give a lot of medicines, surgeons are actually invasive. We actually make cuts, make holes in the body to actually try and make you better. Now beyond being a surgeon, an orthopedic surgeon is a musculoskeletal specialist. So that means we deal in bones, tendons and ligaments, cartilage, all the connective tissue and the hard tissue in the body. So how do you become an orthopedic surgeon? Well, first of all, you have to eat your vegetables, listen to your mom and dad, and keep your room clean. If you don't do those three things, you're not going to get very far, right? Parents, do you agree? All right, good. Well, actually, you have to work hard, you have to be driven, but you have to be really good at taking tests. So starting out, does everyone know what the ACT is? Right? That's your college entrance test. You have to really work hard, do your best, maybe take it 2 or 3 times, get the best score you can. Studying for that test will actually help you in the future for other tests that you're going to take. The next test you're going to take to get into medical school is called the MCAT test. And again, you have to study hard. You can take it more than once. But these tests are the ones that everyone's equal. You know, it doesn't matter what your GPA is from different schools. It doesn't matter what clubs of anything you've been in. This is the one standard that everyone can use to measure you by from everyone else. So you have to really do well on these tests. So once you're in medical school, you have to take your boards. There are 3 parts to your medical boards: Part 1, Part 2, and Part 3. And you have to pass your boards to actually get your MD. I left that one out off the slide. Once you've passed your boards, you need to apply to orthopedic residency. And so once you're in the residency, every year you have to take the same test that everyone else in orthopedics takes, and that's called the in-training examination. Right here. So what that does is it measures how well you're doing compared to other orthopedic residents of your same age. So they compare all the first-year residents, second-year residents, third-year residents, fourth-year residents, and fifth-year residents. And that just kind of tells you how well you should probably do when you take your board exams to actually become an orthopedic surgeon. Now, the first test you have to take once you've completed your orthopedic training is this written board exam. So usually you are done with your training in the end of June. You've got 2 more weeks until you take this test. This is one of the worst tests I've ever taken in my life. I didn't know if I passed or if I failed. We do know that not a lot of people fail, maybe only 3 to 7% per year. So the odds were good if you studied well, you were going to do it. But it's very difficult. It's mind-numbing. So obviously, here I am. Now, you're not done taking tests. After you do the written test, you need to be in practice for, I believe it's 2 years. And you have to keep track of all the surgeries that you do. And you have to make a case list of all these surgeries. And then you have to present to the American Board of Orthopedic Surgeons. And they will pick cases, and you actually have to defend them orally, like a didactic session. It's kind of like you're defending your doctoral dissertation. And they just want to make sure that you're doing things safely and properly. Yes, sir? They do use numbers for their list. That's a good question. Yep. It's a very good question. So once you do that, you are now a board-certified orthopedic surgeon. But your learning's not done. You have to recertify every 10 years to maintain your status with the American Board of Orthopedic Surgery and the American Academy of Orthopedic Surgery. So that's the lowest standard. You have to keep passing those tests upon recertification. And you guys thought you were going to be done with tests after college. All right. Questions, anybody, about that? So, besides the obvious, lots of school and the tests. So, here's the breakdown. You need to do well in high school. The habits you guys learn now about studying, keeping on top of things, being organized, also maintaining your physical health. I know you guys are smart. You're smart kids. You like to read. You like to study. You like to do experiments. You have to take care of your body too, because you have to have a healthy body to have a healthy mind. College, minimum of 4 years. If you go to some of the other schools, or if you are a student athlete, it may take you an extra year or 2. But you need to go to college. And then medical school is 4 years, another 4 years. After that, after medical school, and you get into the surgery part, the actual specialty training, you usually do 1 year of internship. Now, they've changed this a little bit for some of the orthopedic programs. Now it's only 6 months. So residency is actually 4.5 years. Internship is where you rotate through all the different services. So you learn some plastic surgery, some vascular surgery, some cardiothoracic surgery. You do some wound care. You circulate and rotate through all these surgical specialties. So you kind of learn a very broad-based aspect of medicine from the surgical standpoint. And then the residency is the more subspecialized, or I should say specialized training in just the musculoskeletal care. It is very common now to do an extra year of fellowship, which is further subspecialty training, and there are a number of subspecialties within orthopedics. And here is a rather exhaustive list. So Total joints in adult reconstructive, that is usually total knees and total hips and revision of those structures. So what do you think is on the end of this? Does that look round? Yep.
Would that kind of be like the bone inside a knee compartment?
Close. What's connected to the knee bone? Yes! From the back, the hip. Good job. So this is the part of the total hip that goes down your thigh bone or your femur. So this is the stem. And then this ball, actually, it's cold welded on here, but it does come off. But we have various sizes of the balls with various lengths, so we can change that. So this is one of the prostheses. You want to pass that around? It's sterile.
It hasn't been in someone.
I've got some other parts here, too. For a while, it looked like the data was going to be fantastic for a metal-on-metal bearing. And some of them worked well, some of them did not work well. So this is actually the ball that goes into the liner, and they fit very, 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 very snugly, and the tolerance is very close to, in fact, you can still see that's still it was spinning. If you put a little water in it, you can spin it, it'll just keep going and going and going because the tolerance is so close. I'll let you pass that around on this side. So I like doing total knees and total hips and total shoulders. They are very happy people. Sports medicine, that's fixing anterior cruciate ligaments, rotator cuffs. If you dislocate your shoulder, if you have ankle sprains that you keep ruining, that is the realm of sports medicine. So residency and fellowship is 6 years total. So 5 and 1. Yep. So it's a decade of your life. It's a big commitment. Yep. Foot and ankle, very, very popular. That's bunions. Does anyone know what a bunion is? It's when your big toe starts crossing over and the inside starts really getting inflamed. High heels, ladies. That's a big part of it. Yes. Exactly. So hammer toes, a lot of these people also take care of a lot of deformities of children, that are born with like a club foot. And that also runs into the realm of the pediatric orthopedic surgeons as well. Hand surgery, you guys just had a phenomenal presentation done by one of my former partners, Dr. Mark Wilczynski, talking about nerves. Did anyone attend that one? I think that's back in October. No? This is much more interesting. Sorry, Mark. They can take care of a lot of things. They do fractures, wrist fractures, trigger fingers. That's where your finger gets caught because the tendon doesn't glide. He talked about carpal tunnel, where the nerve gets trapped within the nerve in the hand. They also do a lot of nerve repair because they are also by trade microvascular surgeons. If you cut your hands off, they can reattach it. And that was hard. I was in on one on a farmer who hit a culvert. He flipped back, his tractor flipped up, he fell off, and then the tractor went back down, and he had a big sickle mower on the back and went right over the top of him. So he cut off both of his arms and one of his legs, and we reattached him. And I've maintained a relationship with this outstanding person who's really been a productive person after that. But that's a really specialized area of care that the hand surgeons do for reattaching limbs. Shoulder and elbow, this is one of my favorites. I love reconstructing shoulders. People usually do very well. It really improves their quality of life. We talked about pediatrics, that's helping kids. And a lot of the young people that they help, if you have specialized fractures like through a growth plate, if you have spinal deformities, that might be congenital, that's the realm of the pediatric surgeons. There are orthopedic tumor surgeons, orthopedic oncologists, and this is very, very subspecialized. You only usually find these individuals at large institutions like the University of Minnesota or at other major institutions like MD Anderson or some of the other large cancer institutions. Trauma, so everyone's heard of Hennepin County Medical Center or Regions. So if you are hurt badly and you have got like multiple fractures, crush injuries, that's the kind of place you want to go to be taken care of by these individuals that take care of mainly just the trauma. Spine is also a subspecialty too, and that's taking care of collapsed discs, nerves that are trapped, curvature of the spine, and a number of things, so that is very subspecialized too. But a lot of us kind of do what we call general orthopedics, so we kind of do a little bit of some of these things, and I guess I would kind of fall into this area since I do adult reconstructive and sports with a good portion of that being shoulder. Yeah?
Is it only a tractor that can cut down your arms and legs?
So the question is it only a tractor that can cut down your arms and legs? Nope, a lot of things can. Knives, chainsaws, you have to be careful with these things, right? Yeah. All right, so my point is there's something for everyone within orthopedics if you're interested in the musculoskeletal system. So what do I do as an orthopedic surgeon? Well, I have clinic days and I have operating room days. And I try not to mix them up. I try to keep all my clinic days on one day and my operative days on other days. So if I'm late for one, I'm not late for my whole day and run into issues. So what do I do in clinic? I actually see patients. People come in and say, my arm hurts. Well, I might say, well, why does it hurt? Well, I was lifting weights and I was trying to bench 600 pounds and the weight fell. Oh, okay. Did it hurt before? Nope. Well, let's get an x-ray after we examine your shoulder. Where does it hurt? Right here. Like right there. Well, let's see what it looks like with an x-ray. Who knows what an x-ray is? Is it a picture? It is a picture. What is it a picture of? Bones. It's a picture of bones. It's a way to look inside your body without having to actually cut you open and look. Now, an x-ray, we used to use actually film. Does anyone know what film is anymore? Probably not. Yeah. Oh, all the old guys. Yeah, exactly. Just kidding, kids. Now, it's all digital usually, and it's great because digital x-rays actually take a lot less radiation than what we used to have to use for regular film. In addition, it's much quicker. We used to have to develop the films too, and now it's very, very quick, so it saves time. What it does is that the calcium in the bones actually block the x-rays. So that's why the bones look white and the soft tissue and the air looks black. So this is an x-ray of a left shoulder. So it's like this person is facing out from you. And here's the ball, and here's the socket back here. And in this particular x-ray, you can see there's like a line right there. And I can see it better on my laptop. But there's a fracture right there with that double line. So this person fell and probably dislocated their shoulder. Now, say I get an x-ray, and I say, boy, that x-ray looks pretty normal. I mean, you don't have a fracture. There's not a tumor. There's a nice big open space between where the ball is and where the socket is. Now, what lives in that space is a hard cartilage like you see on the end of a chicken bone. So although you can't directly see the cartilage with an x-ray because it doesn't have any calcium in it, so it doesn't stop the x-rays, you can see where the space where that cartilage is supposed to be. So if you see that space getting narrow, then you know that cartilage is starting to wear out. And when it's really narrow, that's what people call bone-on-bone arthritis. Arthritis is wearing out of that cartilage. So this person does not have that. But if you have ruled out fracture, tumor, there's no bony erosion such as with an infection, and you don't have bone-on-bone arthritis, and you say, well, it's got to be something in the soft tissue, then you can get some other tests. And one of the most common tests that we order is an MRI. MRI stands for magnetic resonance imaging. Do I have any budding physicists here? It's a good gig, guys, especially if you can get in an industry like this. So what happens is an MRI machine is a big magnet. And when they put you into the magnet, and they're of varying strengths, you can have a 1 Tesla, 1.5 Tesla, 3 Tesla. Who knows what a Tesla is? It's a car. Yes, it is a car. Very good. It's a unit. He had it, yeah. So it's 1 Tesla is equal to the pull of the Earth's field, 1 Tesla. So 3 is like pretty high, right? But you get really nice pictures. So they put you into this tube. It's about this big. It looks like about the size of a hula hoop. One patient told me it was like going into a coffin, and why he knew that, I didn't ask him. So if you're claustrophobic, you can have some issues there. But you have to go into the tube, and it's long, and you've got to lay still. When they turn the magnet on, what it does is it makes all your molecules line up in one direction. When they turn the magnet off, then all your molecules start spinning again, and when they start spinning again, they send off a signal, and that's what the MRI machine can detect. So that's how you get your pictures. And you thought I just did carpentry, huh? So what I'm showing you here, this is the ball, and this is the socket. Now the white that you see right here on an MRI, you can actually see the cartilage. That's what the cartilage is. Now, this big gray thing coming over the top of the ball that's becoming black right here, that's the rotator cuff tendon. So that's a big tendon. It's made up of 4 muscles, and they go around the ball and actually hold the ball of your shoulder in place. And in this particular individual, on 2 views, you can see there's this white spot here, and there's a white spot there within the tendon. So that's a rotator cuff tear that you can see on the MRI. So what if this person says, well, you know, I see that I've got a rotator cuff tear here, and, you know, I don't want to have surgery yet. It's not bothering me that much. You know, maybe I know it'll get bigger with time, but I have to get through gardening or hunting, or, you know, I've got a big meeting coming up. What else can you do? Well, I do injections in the clinic as well. That's a procedure that we do. And a lot of times, you know, if we've been treating a patient for a while for any number of things, if they've exhausted all the reasonable non-operative options for that particular thing, be it a tear of the meniscus in the knee, or arthritis of the hip or the shoulder, or a rotator cuff tear, and they say, look, I've had enough, I just can't do this anymore, well, then we can schedule them for a surgery. And so we do that in the clinic as well. And then after the surgery, we also see them back at the clinic to see how they're doing, to make sure that everything's going well. So that's what a normal clinic day is for me, and it's busy. So we, you know, besides injections, we can do other things in the clinic as well. Say you fell down and you landed on your arm. Say you fell off your skateboard, which I was not allowed to have as a kid because my dad was a doctor. And we got an x-ray, and lo and behold, you broke your wrist. But say it's just a crack, you know, it's not a part, it's not angled. Well, we can put you in a cast, and we can do that right in the clinic. Maybe if there's swelling, we'll put you in a splint instead of a cast. Does anyone know the difference between a splint and a cast? Back there. Well, you've got kind of the right idea. Anyone want to give it another try? Nope.
Casts are hard, so there's no room for the swelling to grow.
Boomba. He said casts are hard, so there's no room for swelling. So a cast will go all the way around. They're much, much more stable because they're circumferential, but you're absolutely right. They give you no room for swelling. So a splint usually has at least one side that's not hard, so that'll allow for some swelling. Bad swelling in a cast can actually cut the circulation off in either your foot or your arm, so that's not a good thing. So if you have some swelling, we'll usually put you in a splint. Maybe you've had a fracture for a couple days, you know, maybe, you know, you thought, oh, it'll go away, and it just didn't, and the swelling's better, then we can put you in a cast. So if I, with my patient, come to the realization that we have done everything we can short of surgery, that's all called what we conservative care. Conservative care is non-operative care. And that consists of, I'm getting smiles from my patients in the crowd. That consists of usually giving it time to see if it gets better, modifying any activity that may exacerbate it, using oral anti-inflammatories like ibuprofen, Aleve, maybe using Tylenol, using ice or bracing, physical therapy, injections. And if all these things have not worked, then we can talk about surgery. Now, in general, the goal of surgery is to make you better. Maybe not perfect, but better. And for a lot of people, if whatever we're dealing with makes you 90% better, is that a good deal?
Yes.
Yeah, I think it is. I would agree. And we want you to function better. You know, what if you can't walk? What if you're in a wheelchair? If I can get you up, and at least if you're using a cane, is that better? It's better. Yeah, exactly. We also talk a lot about the other alternatives if they have not exhausted all the things that I just mentioned, such as physical therapy, medications, injection, bracing, and so on. We also need to talk to them about the risks of surgery. You know, going in for surgery, guys, is not like going and getting your hair cut. I mean, this is a big deal because a lot of bad things can happen with surgery. The one thing we worry about, anytime we cut the skin open for any reason is the risk of infection. Your skin is your barrier to the outside world, and we're violating that barrier. So we do everything we can to prevent that. We scrub the skin with an antiseptic solution. We give you antibiotics. We're careful with how we handle the skin, but it still can happen. Depending on the size of the surgery, we might worry about bleeding. So say you're having a huge spinal fusion or you have a huge revision hip, your risk of bleeding is much greater than, say, if you're having a trigger finger release or a carpal tunnel, but that's something we need to talk about. And anytime we're working around nerves or blood vessels, we can stretch them, they can be damaged, and especially if you're doing surgery the second time around or third time around, that's called a revision surgery, there's a lot of scar tissue. And sometimes the nerves can be stuck in that scar tissue, and you've got to be very, very careful that you do not damage them while you're trying to accomplish your goal with fixing the person. Anesthesia can be dangerous too. Now, what we try and do for any surgery, if we can, is to use as little anesthesia as we can. So a lot of times we'll do like a block of the nerves and just sedate people, as opposed to putting the tube down your throat and having what's called the general anesthesia. So you can have nausea from that, but you know, you can even, anesthesiologists will tell you there's all sorts of things that can happen with that, so you got to be careful. I actually had one patient get hit by a car coming to surgery. You talk about bad luck. Now, I don't usually mention that as a risk of surgery, but I guess anything's possible. So just remember that if you ever need any kind of surgery, that there are risks associated. Usually everything goes fine, but things can happen. Now, I see by patients after surgeries, just to make sure that any surgical incisions we made look good, we want to make sure there is no infection. We want to make sure that they've got enough pain medication to keep themselves comfortable. We want to make sure that they're actually not just doing their therapy if they need it, or going to therapy if they need it, but they're actually doing their therapy. We want to make sure that they're keeping their spirits up and they're going forward. Now, if you do surgery, we break this down into two types. Inpatient surgeries, where you actually stay in a hospital or a care center for a while. And those are usually the bigger surgeries that we do, like hips and knees and shoulders. The other reason you might do it in the hospital is, say you're not in great health or you have no support at home to take care of you. So you might do what might be considered an outpatient surgery as an inpatient if you meet those criteria. Outpatient generally means that it's a smaller surgery and you're going home usually the same day. So there's a couple places where I operate. This is Abbott Northwestern campus. This is the VA Medical Center. And this is Crosstown Surgery Center in our main Twin Cities Orthopedics office in Edina. Some of my friends, you guys, this is a team approach. I cannot do this orthopedic surgery gig by myself. I am really dependent on everyone that's with me, and you know, you're only as good as your team. So the other things you've got to cultivate are your people skills too. You need to be good to your staff. You need to listen. You need to, and a lot of them are really smart too, and they've got good ideas. Take those under consideration. Buy them coffee once in a while. Make them happy. So we've got our anesthesia team up here, and you can see all these machines. Those are to make sure that the heart's running well, the lungs are going during the surgery. This is actually. We're doing part of a knee replacement right here, so you can see the blue drapes. Everything that's blue in this field is supposed to be sterile. So if you don't have gloves and a blue gown on, you're not supposed to touch any of this stuff so you don't contaminate it. And then finally, I didn't have a lot of gray hair in this picture, so that must be an old picture. But that's if we're doing, you can see the screen back here. Usually when you're doing outpatient surgery, a lot of times we'll do arthroscopic surgery. So that means you're using a fiber optic camera and light source, and you're looking at it on a screen above. So let me do two case presentations for you to kind of give you an idea of what we do. And both of these are outpatient surgeries that we're describing. So this first guy is a 43-year-old male, and he's getting increasing discomfort in his right knee. He notices it whenever he golfs and whenever he tees off, and when he twists, he can feel it. He's feeling catching, so it feels like something's giving. And then when that happens, the knee will really swell up. Let's assume that I take a look at his knee, and sure enough, right on the inside, so right here on the inside, that hurts. And when I twist his knee, he says, yep, that's exactly the pain I feel. Well, if his x-rays look good, if he's got no arthritis and there's no fracture, this sounds like he might have a problem that's very common. We'd get an MRI, and sure enough, this gentleman has a tear of his meniscus. I apologize, I usually bring a knee model up here, but if someone says they tore the cartilage in their knee, they usually mean this meniscal cartilage. It's a very tough, rubbery cartilage, unlike the hard cartilage that's on the end of the bone. So the meniscal cartilage is supposed to protect your hard cartilage, but if you happen to twist your knee, you can tear your meniscus. Even like this is a shock absorber, so even like the shocks in your car, with time, they can start wearing out, and you get some fraying, you can get a degenerative tear. So what I'm trying to show you here is it's two big rings. You got one on the inside, and one on the outside, and you've got one on the inside. And usually where it's torn is kind of right back in this corner. Now this is an MRI of the knee, and this is your thigh bone or your femur. This is your shin bone or your tibia, and then this is the front, and this is the back. So this is right here. And can you guys see that white line going up in the meniscus? That's the tear. Now I'm going to show you the surgery. Just to caution you, this is not gross. There's no blood. Because with arthroscopic surgery, if there's a lot of blood, we cannot see. Let's see. Is it running? Wonderful. So this is the kneecap right here. Nice shiny white cartilage. And then this is the groove of the kneecap, right? Now you can see this cartilage in the groove is really starting to kind of wear out. You can see those chunks. Now we're going to the inside of the knee. You can see some of those chunks of the cartilage that broke off from the groove are actually floating over here. And then now we're going to the inside of the knee right here, and that's where the tear is, which is way back here. And I'm going to get a probe in there in just a moment. I'll be able to show that a little bit better. And there's another piece of that cartilage that's going to floating by. So my probe, you can see there's a split right there. That's that split you saw on the MRI right back there, and there's a split as well. So you can see those little pieces when they flip out into the joint. That's the catching you feel. They hurt. Here's the anterior cruciate ligament, which is right in the middle of the knee. And now we're going to the outside of the knee. And then this is the lateral meniscus, and you can see there are no tears there. That looks really, really nice. And then finally, this is the lateral gutter. This is way on the outside. This structure right here is called the popliteus tendon. And there's only two tendons that actually go in a joint. One is the popliteus here, and the other is the biceps tendon, which I'm going to show you when we do our next demonstration. All right, so I have a little shaving instrument. This spins at about 1,200 RPMs. It's got some pretty sharp teeth, and it's got a suction in it. So you can see I am just trimming up the torn piece of that meniscus. Now, we try and leave as much of the meniscus behind as we can. We don't want to have it lose its shock-absorbing effect. But the piece that's torn, especially if this is more of a degenerative tear, unfortunately, we can't fix that. I can't get a stitch or an anchor in there because the piece just isn't big enough. Plus, this portion of the meniscus really has no blood supply, and you do need a blood supply to heal. So we're just trimming up this torn part and sucking it out. Exactly. You can see this goes pretty far back, so this is a fairly good-sized meniscal tear. And you can see that the pieces aren't floating all over the knee. They're being sucked up by the vacuum that's inside there. Now you can see I'm trying to keep the smooth part of this next to the hard cartilage so I don't scratch that. Because once that hard cartilage is scratched, if I went back there 5 years later, that scratch would still be there. It has a blade on the end. Yes, sir. It spins. Now, this is a very sharp little arthroscopic scissors. So I'm just trying to contour this. I can get in there a little bit better with this scissors. And what I want to do is make sure that I've got all the tear smoothed out. Think about if I tore this piece of paper, I had a little nick in it. And if I keep pulling on it, what's going to happen? Let's keep tear, right? So that's kind of like if you walk on a meniscal tear, it's going to keep getting bigger. What if I took a scissors, like I'm doing in the knee, and smoothed it out? Is it going to tear? No. So that's kind of what I'm trying to do also with this, is I'm trying to eliminate the tear so the tear doesn't propagate any further. Again, we want to save as much meniscus as we can. Because if you lose a lot of meniscus, the knee, that part of your knee is going to wear out. You might need more surgery later on, possibly in the form of a knee replacement. So the question is how do I decide how much I need to take? I take anything that's loose and frayed and can be pulled into the joint. It's a good, very, very good question. But we try and leave everything we can behind that we can. Once we take it out, it's gone. That's why if you have an acute tear and it's a large tear, we will try and actually fix that rather than do what I'm doing here, debriding this very frayed meniscus.
So you mean it won't grow back?
It does not grow back. Meniscus don't grow back.
So will it be like a permanent damage, or will it just...
Well, this is a permanent change. Yep. Yes, sir. So in this gentleman, this was probably a degenerative tear, just with use and time. If you're a super active individual, maybe you're a little overweight, that's usually what happens. It can happen just with time. Yes, ma'am.
What would you do if you totally accidentally messed up and you made the tear worse?
Oh boy. Retire. The question is, what would I do if I made the tear worse? You got to be really, really careful. I guess that's the best answer. Okay, be conservative when you're taking this. Now you can see I'm also smoothing down the cartilage that's in the trochlea, that's in the groove where the kneecap rides. There was another question. Yes, ma'am. Why is there no blood? That's a very good question. Why is there no blood? Cartilage has a very poor blood supply. That's why it can't heal themselves. So if hard cartilage could heal itself, we wouldn't be doing hip and knee and shoulder and elbow replacements. That'd be great. I'd have more time for a lot of things, like giving lectures to young scientists. Way in the back. How long does this take? Well, this is real time, guys. So what's it been, about 7-8 minutes? Yeah, so these are usually fairly short surgeries. They don't usually take that long. That's it. All done with the surgery. Yes, sir. Fix it. Yeah. Does that entail? So yeah, so if the question is this, so I said if it's an acute tear, if there's a large piece that's torn, but the tissue, as you saw, this was very frayed. It looked kind of like crab meat. But if there's a large chunk that is amenable to getting a stitch or an anchor in, especially in a younger person, we can actually fix that instead. We try and put that back and try and incite the meniscus to grow together if we can. Yep. So that's a great question. How did I see inside that leg? I have a little camera. It's about that big around, and it's on a long little tube. And I make a little incision about that big through the skin, and I go put that little camera in the knee. And it's got a fiber optic light source, so it's super bright, and it's got a camera on it. So that's how I can see in there. Pretty cool, huh?
But if I cut around my knee and stuff, there's still blood.
Right, so you're right. So the question is, if I cut my knee, there's still blood. The skin around the knee is very well vascularized. The bone itself is really well vascularized. That's why usually fractures heal so well. But the cartilage, unfortunately, both the articular cartilage and the meniscal cartilage does not have a great blood supply. So the bone, you can actually see some bone, and that's right here. So this is early arthritis, you guys. This is wearing out of that cartilage.
So is the reason because your ears are cartilage? Is that why when you get ears pierced you don't bleed?
So the question is if your ears are cartilage, when you pierce your ears, they don't bleed. I think that's if you get like a cartilage piercing, which your mom probably is not going to let you do. See? Yeah. How do I control the camera? Well, so I mean, I'm literally doing this with my hands as I'm looking up the screen. I bet no one plays video games here, do they? No, I don't believe it. Parents, you're going to hate me for this, but if you have budding orthopedic surgeons, let them play video games. And have them take 1 year of shop class. Those are the motor skills they need to do this. It's the same thing. I mean, urology, gynecology, there's a lot of other surgical specialties that kind of do the same thing with scopes and looking at a monitor. It's the same motor skills. So you're looking at the monitor while you're moving your hands. That's why a lot of the generation ahead of me who never played video games really did not have that coordination. So, I mean, we could take any of these kids and put them in a lab, a simulated lab for arthroscopy like this, and they would kill it, because they have those motor skills. Yeah. So the question is, why do I need to vacuum away that extra stuff? Well, if I didn't take that extra stuff out of the knee, it'd be floating around in there, and it'd get caught, and that would hurt. So we just want to get rid of all that extra stuff so it's not floating in there. Yep. About how big? So the question is, how big is this? And that's a good question. Can you guys see the tip of this probe right there? That's 3 millimeters. How big is 3 millimeters? Hold your fingers up. Perfect. So if you look at this, so that's 3, and would you say that's maybe another 3 out there to the tip, and about 3 there, and about 3 there, right? So that's how you estimate how big that is. So it's about 12 millimeters wide, right? That's how you can measure. I'm sorry, you have to speak. I got this fan running right here. So the question is, I said the cart was just floating around. What exactly does that mean? That means it's not attached anymore. It's actually free and moving around. And okay, so when I was doing this, we actually run a lot of saline through the joint. So that keeps all the blood and everything away and expands the joints. So it was floating in the saline here. But, when you swell up, it's actually floating in the joint fluid. Yes, sir?
Why is there liquid in our joints?
So why is there liquid in our joints? That's a really good question. Well, our joints are bearings, just like the bearings in your car. And so you need lubrication. So in that fluid, you've got a lot of big protein molecules that attract a lot of water, and they help lubricate the joint. That's a very good question.
Can we take the questions at the end so that everybody will be able to hear the questions?
Oh, sure.
Thank you.
Yep. Okay. All right, should we do another one? All right. So I have an extremely active 72-year-old female. She still does Pilates. She still does yoga. And she brought me in a batch of cookies. And she's just kind of developed pain over time. She's noticed that, when she's doing some overhead presses, it hurts. If she's trying to get something off the top shelf, she's getting pain right here. The big thing she noticed was that she'll wake up at night and her shoulder hurts. It just hurts. Even though she'd been sleeping, it'll wake her up. And you know what? She thought it'd get better. She thought she overdid it in the gym, and she thought she'd give it some rest, try some ibuprofen, some Tylenol, and icing it down, stop going to the gym for a while. It's actually getting worse. Now, she'd already been to another provider who said, well, let's try some cortisone injections and some physical therapy. That's a really appropriate thing to do, actually, especially if our x-rays were normal. And unfortunately, that didn't get better. So again, She probably has normal looking x-rays where there's no arthritis, the joints are not narrowing. And so this sounds like she probably has a tear of the rotator cuff. So this is the same picture that I showed you before. You can see right here where we've circled it, there's a gap between the tendon and where the tendon should insert right there where it's white. So your ball and socket joint for your shoulder, it's a very unstable joint. That's why you've got such great range of motion, because it's not constrained. So the socket is actually very flat, and the ball sits on it, so it's almost like putting a golf ball on a golf tee. It's not really stable. The other analogy we like to use is it's like a seal balancing a ball on its nose. I don't know if anyone sees that anymore. So you're really dependent on the soft tissue attachments to the ball to hold it on the socket, namely this rotator cuff. So you've got 4 large muscles. So this is the subscapularis, you've got the supraspinatus over the top, the infraspinatus here, and the teres minor that come and make this one big large tendon that goes around. And this is the most common area where you see the tears in the supraspinatus, which is the one over the top, and that's this right here. So if someone says they have a rotator cuff tear, they usually mean the supraspinatus. So she wasn't getting better. It was getting worse. She had tried everything reasonable non-operatively, so the next option would be surgery, exactly. Now, before I start this video, we are in the space above the rotator cuff, but below this part of the bone right here. This is called the acromion. So if you touch the side of your shoulder right here, that's your acromion. That's part of your shoulder blade. So the rotator cuff has got to go underneath that. Now, you asked me a very good question about fluid in the joint before for lubrication. If you don't have hard cartilage, but you need lubrication somewhere, you can have a structure called a bursa. Who's heard of bursitis? Everybody, right? Yeah. So bursa is very thin. If you hold it up, it's almost like looking through wet tissue paper. It's usually just a few cell layers thick, but it secretes a very slippery fluid. So common places, shoulder, you can get bursitis, elbow, knee, anywhere where the skin or something has to glide over another structure, you can have, there's a bursa there to help lubricate it. Bursitis is inflammation of that bursa, so you're going beyond that bursa's ability to lubricate properly. So this pink wispy stuff right here is really inflamed bursa. Oop. Now there's going to be a little bit more blood here than the other video. So I am using a cautery device right here, and what it's doing, it is literally melting away all that diseased bursa tissue. And cauterizing means that you're stopping bleeding at the same time. So you can see that stuff is just kind of melting away. The rotator cuff is this big white thing down here, and she has actually a big spur coming off the acromion and the end of her collarbone right here. So we're going to get rid of that spur too, so there's plenty of room for that rotator cuff to move through that space. So when I'm doing this surgery, the person is actually sitting up in what we would call the beach chair position, and it's exactly what it sounds like. You're kind of semi-reclined with your legs up, and no, you don't have a margarita in the other hand. We provide that for you during surgery. And most of the time we can do this with a nerve block, meaning then we can just sedate you to the point where you're snoozing comfortably. We don't usually have to put a tube down your throat. And then you actually feel pretty good coming out of this type of surgery. So what I'm trying to show you here with my probe, this is a big spur right here. Now this is the end of the collarbone. Now any of us that are over 40, we are already starting to get a little bit of arthritic change in that end of that collarbone, even if it doesn't hurt. But it's a very small joint. It's the only bony attachment your arm has to the rest of your body. So everything you've ever done, you've put force through that joint. So that can often be very sore. Now this probe is grabbing the edge of the rotator cuff, and you can see there's the tear, and I can pull it right over where it should be inserting. So this tissue still is of very good quality. It's very robust. It's also very mobile, so it will come over quite nicely. Now this is a burr. This spins at 10,000 RPMs, and just like my shaver that I was using in the knee, this actually has a little vacuum in it too, so it sucks all those particles out so they don't float around and get caught. So you can see I'm taking that spur off. Now that does two things. it actually opens the space up so I can see better, but it will also open up that space up so once that rotator cuff is repaired, it's not going to be hanging up on that spur at all. So that's called a decompression, and this is kind of a standard part of my operation when I fix the rotator cuff. So I haven't even started with the cuff yet. Now you can see this little bit of, oh, it looks better on my screen. You can see there's a little bit of bleeding from this bone. Again, bone is very vascular. So what we do to counteract that while we're doing the surgery is we pressurize the saline that we're putting in the shoulder, and we also chill the saline. And we put a little bit of epinephrine in it. And that's a potent agent that causes constriction of blood vessels. So that all helps with my visualization. Questions about that so far? Okay. Why do I what? You don't have to, but I thought I'd show you what I do. Is that okay? Let's see. Yes, sir.
How does that chemical constrict blood vessels?
Oh boy, the question is, how does epinephrine constrict blood vessels? I think it acts on the muscle and makes them contract that's in the blood vessels. Exactly, it makes the muscle shrink. Yeah. It does too. It sucks out the fluid along with the little particles. So now you can see that that spur is gone and the space is much more open. Now what I'm doing is I'm burring off the very tip of that collarbone. Now, when that collarbone gets arthritic, that's just bare bone back there. By taking off just the very tip, what will happen then is you'll get some bleeding in that space. We leave the thick capsule around the joint intact. That blood, which is called a hematoma, that will organize and will become a nice big thick layer of scar tissue. And this is one of the few little joints in the body you can do this with, but that will biologically resurface that joint right here at the collarbone. It takes about 3 months, and so it takes no more time even if you're doing a rotator cuff tear. But that can also cause people pain too, so we take care of that. Yeah? I can't hear over that fan. So we make little incisions and we actually push them in. That's a very good question. How do we get the tools in the body? So this is arthroscopic surgery, small incisions and small tools that are kind of on long tubes that we can get in with it. Now, let me back that up for just a second. Maybe I can't. So we've done the decompression. We've taken off the end of the collarbone. Now I'm going to put some anchors in the humerus into the arm bone so I can actually put the rotator cuff back down. So what I've done first, this is a punch. And so I've made a hole in the bone right there. Now the next thing you're going to see coming in, this is called a cannula. So if I don't want to have any soft tissue caught, that'll allow me to pass instruments freely through, it's kind of like an airlock, if you will, and lets you pass through. So I've just put an anchor, you can see the swivels right here, and that will go into the bone. Now this is a tape, it's a very tough tape. This is made out of Kevlar. Who knows what Kevlar is? What do we make out of Kevlar, guys? Canoes, quinoa, exactly. What else? Bulletproof everything, right? Exactly. So tough stuff, really tough stuff. All right, now what I'm going to do is I'm going to pass those Kevlar tapes through the rotator cuff. So I use a simple stitch first. I pass this through the cuff. You saw that little needle come up. This is like a little hand sewing machine. And my assistant, who's trying to do this backwards and upside down, has to grab that. Now that suture's got a big loop on the end, so I can actually pull the other 4 strands from the anchor through the rotator cuff, and you'll see that happen in just a moment here. So instead of having to pass them all individually, this saves time, and it only makes one hole through the rotator cuff. So you can see the other sutures are right here. I've got to pull those out, and then we're going to feed them and shuttle them through. Now you can see there's a little bit of blood. It's actually coming from right down where that anchor was. So now we've passed one suture through. Now I need to do another anchor. So I'm punching another hole. Back to the carpentry thing. Good quality bone, it feels like good quality wood. So it's a very similar feel. And this person has very good quality bones, so that it will hold the anchors. So there you can see some frayed rotator cuff. And here we're going to put another anchor down. And again, guys, this is real time. Yes?
So, I have two questions. It's so small, so how do you keep a steady hand? And two, how do you train the first time you ever do it? I don't know that I want to be the first patient, so I'd like to learn more about how you learn.
Sure, that's a really good questions. Number one, how do you keep a steady hand? Less than 3 cups of coffee in the morning. And you know, it's knowing what you're doing, confidence, so you're not nervous too. So that goes into the training. So what we do for our residents when you're training is we actually have you work on simulators first. Okay. Now, this actually, what you don't see is my assistant helping me outside this. This takes 2 or 3 sets of hands to do. So you might start out by just holding the camera, you know, to show us what's going on here. Kind of getting confident with that. And then maybe we'll let you kind of drive around a little bit to look. So that's how we start people out. You know, so that's why it takes so long. I mean, this is, you know, you want to be safe. You know, so that's a very good question. Simulators have become really a big thing, and just getting the repetition. I mean, just if you're even holding the camera and I say, now look around the shoulder and see what you see, that's valuable training. So now we're putting a third anchor in. Now, what we want to do is give that rotator cuff as large a surface area to heal down as we can. So we took the sutures from the other 2 anchors and we pulled them over the rotator cuff, and I'll show you that after we put the 4th anchor in. You can see actually the blood coming from the center of that anchor. See that? So that actually will allow some of the deeper blood to come up and actually help that rotator cuff to heal down. Now the next thing you're going to see, I'm going to bring a little arthroscopic scissors down, and we're going to cut those Kevlar sutures off.
Why would you not clean up the rest of the frayed tissue before doing all the anchors?
Good question. So I cleaned up most of it. There was just a little bit left there. So, you know, a little bit of frayed tissue is okay, especially if you think that the stuff behind it is still pretty good quality. What you saw there was fairly small. So the question is, why did I leave that little bit of frayed tissue there? Good question.
Dr. Hunt, it's 8 o'clock, so we have to wrap it up.
I'm sorry?
It's 8 o'clock, so we need to wrap it up.
Okay, so we're almost done. All right, so there you can see these sutures crossing, and what you don't see is the hole in that rotator cuff anymore. Ta-da! Part of what we have to do also as orthopedic surgeons, if you have people in the hospital, you need to go see them and make sure things are going fine. These are 2 of my PAs, and they round for me as well. A lot of times people ask, how are they doing rather than how am I doing? Because they like them so much, because they take good care of them also. It's part of the team. We also take call. So if you are on call, that means that if people call up and have acute injuries, broken bones, infections, if they've dislocated a shoulder or hip, you need to see them as well.
Thank you, Dr. Hunt.
Thank you for your attention.